Hi, I'm Dr. Allan Perel. This is Conversations in Medicine. This program brings cutting-edge topics to the community. We try to stay on medicine, but sometimes we go off it. But tonight we're going to talk about something that's very dear to me, multiple sclerosis. There are about 1 million people in the United States with MS. And every time at our center, I run the Multiple Sclerosis Center of Staten Island, every time we tell someone they have MS, clearly that's a devastating diagnosis. Where we've come over the last 30 years, our center is celebrating its 30th anniversary, has been absolutely amazing. When people were diagnosed with MS 30 years ago, before many what we call disease-modifying therapies have come out, the odds were 50% that they'd need a cane within 15 years. About 50% that within 20 years they'll need some kind of a walker or wheelchair. It doesn't happen anymore. The numbers are much lower. Less than 10% of people will need assistive devices who are diagnosed now. And that's because we have highly effective agents, medicines that work very, very well to reduce the inflammation. And we have a team at the MS Center of Staten Island. I'm very proud of our team. I'm Dr. Perel, I'm the medical director, and I have one of the key members of our team, someone who's been there for 6 years, who I learn a lot about, another doctor, nurse practitioner, Daniel Ostrowski, and it's my absolute privilege to have you here, and it's a pleasure to see you.
I appreciate it. Thank you. Thank you for having me.
So Dan, at our center, and our patients are so interested in MS. There are about, I'm saying, 1 million people in the United States with MS. The odds of getting MS is about 1 in 1,000, give and take. That's about 500 people on Staten Island. But with other people that are involved, family members, it seems like there's a larger number than even that. People come to us from all over the tri-state area, even Pennsylvania, and it's really nice to have people who are happy to get care at our center. So when you see all the patients that we have with MS, tell me a little bit about what you think about them, and how do you look at them any differently than anybody else, or anything else you have to think about?
Yeah, good question. So I mean, MS, it comes in all different shapes and sizes, so to speak. So we see them when they're diagnosed very early on. Sometimes we see people diagnosed, middle age. But in terms of diagnosis and treatment, we try to be aggressive first line, just to kind of halt the disease, hopefully in its place, and keep their mobility, most importantly, and keep symptoms from progressing. Predominantly, we see mostly in women are more affected than men, and what we're seeing is Caucasian people seem to be more diagnosed than other races. Although we're seeing a rise, I think, in African American people as well.
So tell us about the team. So I'm on the team, you're on the team. Why do you need a team?
Because it's a multiple disciplinary attack. It takes a lot in order to get medications approved. It starts with the front desk. Obviously, they greet the patients. We have MAs, nurse practitioners, as well as myself, another nurse practitioner. We have other neurologists that work with us, social work. There's many different aspects that go into treating multiple sclerosis. It's more than just a diagnosis. And a lot of people work behind the scenes, and as I said, getting medications approved, which can be a very lengthy process, these medications aren't cheap. So a lot of prior authorizations and appeals and denials. So it is a process, and it does take a team to get this kind of work done.
And even diagnostically. So the diagnosis of MS is made clinically. We see someone and see how they're doing with regard to their symptoms, their age. As you said, younger women oftentimes will get MS. There is a small genetic component to it. If you have a first-degree relative with MS, the numbers go up, that you'll get it. But if you don't, there is still a possibility that you will, so it's not something that's purely genetic. We say that it's also sporadic. And the diagnosis is made basically on the clinical grounds. People will come in with blurred vision, numbness in their arms and legs, and this is not to make everyone anxious. Sometimes we all sleep on our hand and it's awkward, and you wake up and you have some tingling in your fingertips. We really are talking about things that last hours to days to even longer. But blurred vision, especially in one eye, double vision, relatively new onset bladder problems, especially in younger people. Those are all signs that we have to worry about it. What I think is so amazing and what's so difficult is that sometimes people will have to wait years to have their diagnosis made. And that's because many healthcare people, and again, myself included, someone comes in with very non-specific symptoms like some numbness in their hands and feet, and we'll say, well, it's not MS or it's not anything bad. It's stress, you just were laying on your arm the wrong way. And it takes a lot longer to make a diagnosis. And really diagnosing people early and using therapies early are really what's so crucial. So Dan recently got his doctorate in nurse practitioner.
Thank you.
It's actually a doctorate in nursing.
Doctor in nursing,
Yeah.
correct?
That makes you a DNP, so there's a lot of doctors at our center.
Yes.
And I can't tell you how proud all of us are.
I appreciate it. I couldn't
And,
have done it without you.
and everyone loves Dan, of course. You did this paper, and I know I was one of the
Yes.
mentors and one of the people involved with it, or sponsored, I think the word is, and it was a very interesting study. So we have a lot of patients who have MS, and as you're going to talk about, one of the major concerns is really the fatigue that people have with MS and the anxiety. As you know, in my generation, everybody thought of someone like Annette Funicello, a woman in the 1960s who was a movie star who wound up in a wheelchair. Now we think of different actors such as Selma Blair, Terry Garr, who recently passed away. And again, she passed away in her late 70s. So most people with MS do live a very close to full lifespan because of our new treatments that we have. But so many people, we sort of have this mental image of how they're walking, how they're talking. Medicines are now direct to consumer. We see people like the young lady from The Sopranos. We see people talking about different medicines that they're taking. And these highly effective agents really have changed things. But still, to the individual person, when we give them their diagnosis, there's a tremendous amount of anxiety. And I know you really dedicated your thesis, your paper, that got you your doctorate on anxiety. And I've heard the paper, and I really, part of the reason I wanted to have this tonight is, again, to talk about our MS Center, of course, and really to have you talk about what you found with our patients. And again, this a lot of this generalizes, but I think, I'm going to let you talk a lot about this, but a lot of this generalizes to other chronic disorders, illnesses. People with Parkinson's disease we see, even people with migraine headaches that affect their lives, people with chronic back pain that we see a lot of in the office. But multiple sclerosis specifically is what we were looking at, and we see that anxiety and fatigue are such a major factor. And maybe tell us a little bit how the paper was set up, and what did we find?
Yeah, of course. So it was a quality improvement project that focused on improving screening and management of anxiety and depression in patients with MS in our particular clinic. And the reason why I chose this topic was because a lot of times we focus on the physical aspects and we forget about the mental health aspects. So fatigue can overlap. It could be signs of depression. It could be, even signs of anxiety because, racing thoughts and you're kind of running so high all the time. And it could be overlooked as, maybe just a typical MS symptom, but it could be something else. So I decided to take a different approach in terms of just evaluating to see if patients are being evaluated for their mental health symptoms. And what I found was there was a lack, and I feel like it does go across other specialties as well. I feel like other than psychiatry, where that's what you're looking for, anxiety, depression, what you're treating, a lot of times we handle the physical, we forget about the mental health aspects. And it does play a huge role in terms of, symptoms and progression of their physical symptoms of MS and any other condition as well. It could worsen them, especially if they're not feeling well. They're depressed, so they're not getting out of bed, so they're not moving, so they can have weakness. Even numbness and tingling can worsen. That's also could be a sign of anxiety, depression. What I found was that it wasn't being assessed enough, and I think adding in the mental health aspect with the physical aspect really looks at the patient as a whole, and it's all about patient-centered care. So it was interesting to see. And I definitely think it could be used across other specialties as well, for sure.
So tell me, I know part of the study was actually having a checklist for people.
Yes.
And we've set that up at the office, where when someone comes in, we ask the questions. We want to know if you're anxious. We want to know if you're depressed. We want to know if you're fatigued. We want to know what symptoms you have. So what do you do if somebody's checked off that they are?
Good question. So in my project, I used the Beck Anxiety Inventory Scale and the Beck Depression Inventory Scale to screen them to see if they were present, if they had symptoms present. And they were graded as minimal, mild, moderate, or severe. So if you scored in the minimal to mild range, you received a certain number of checklist items. And that can include things like MS support groups, exercises for patients with MS, whether they're mobile or if they're not mobile, wheelchair bound, things like chair yoga, mindfulness apps to practice mindfulness. In terms of diet, anti-inflammatory diet has been shown to be helpful. As
so
MS
let's talk about diet for a
Yep.
second. Well, I'm going to even take, because diet is one of the most talked about things in our practice.
Sure.
So people with MS all are asking, and their families are asking, what kind of diet should anyone be on? And I don't know if you know, there's a man named Swank back in the 1970s who came up with this interesting diet as an anti-inflammatory diet. And really diets have come in and out of favor. Now I think the Mediterranean diet is probably one of the diets that we've seen most. And again, not to interrupt what we're talking about with the whole topic, diets, what diet do you recommend for patients with MS?
I have to say, I agree with the Mediterranean diet. It seems like the most accepted diet that just...
And what is the Mediterranean diet?
It includes like fish and nuts, kind of like you're staying away from fried foods, greasy foods that all can cause inflammation in the body. Yeah, I mean, inflammation, MS is an inflammatory process, as is a lot of other conditions and diseases, an inflammatory process. So trying to eat clean and try to exercise are the most important things, you can do.
Mm-hmm. So with MS itself, so we talked about this, and maybe go back to some of the definitions a little bit. What's anxiety?
Anxiety, it can mean many different things, but racing thoughts, unable to shut your mind off at nighttime, kind of always being at this heightened level of constant fear or worry or angst. You can have physiological signs of anxiety, like feel like your heart's beating on your chest, or feel sweaty palms or red blotchy skin. It can manifest in many different ways. There can be many different triggers for it, and some people don't even know they have anxiety because they're so used to being in a constant state. So yeah, I mean, getting diagnosed and getting treated, whether holistically or with medication, can really improve patients' lives and symptom management overall.
What's depression?
Depression, good question as well. Basically, it's when you're feeling down, and it can manifest as having no energy, fatigue, you just can't get out of bed, no motivation, sad, and again, that also can further progression of disease if you're just not motivated, you're in bed and you don't want to engage with people and no drive to really do anything. Bouts of crying, and it can be triggered from an event, a stressful event in life, or multiple events that maybe just weren't talked about or really addressed appropriately.
And these surveys that you do, again, all of us have been down,
Mm-hmm.
all of us have been anxious. The idea to meet that criteria of having an anxiety disorder or depression disorder, really that's where that questionnaire really is a validated questionnaire. There's about 20 questions about,
Correct. Yep.
and you see how many of them are yes or no,
Mm-hmm.
and it really does give us a pretty good idea if you are depressed, clinically depressed, if you are clinically anxious.
Mm-hmm.
Now let's go on to fatigue. About 95% of patients with MS have fatigue.
Mm-hmm.
And we divide it into primary fatigues and secondary fatigues. The primary fatigues, it's just you're tired. So people always think that patients or people with MS are tired because they can't walk well. And they did a study about that. They took people with, say, rheumatoid arthritis. And they said, they took both groups, and each group could only walk about a block. The rheumatoid arthritis patients because their joints hurt, the MS patients because of stiffness and brain issues, because MS is a disorder, as you know, and just to tell our audience, of the brain and the spinal cord. What we basically have is inflammation, and the body attacks the covering of the nerves, the myelin. So it's attacking both the nerves in the brain. It is a central nervous system process, and of the spinal cord. That's why people get blurred vision, weakness in their arms and legs, and stiffness. So when you think about it, so MS affects those areas. So fatigue, they did that study, and they found that people with rheumatoid arthritis had much lower levels of depression and fatigue than people, even though they walk the same amount than MS people. So it looks like there's certain chemicals in the brain. And because of the inflammation that occurs, as we said, there's an inflammatory process, it almost brings us back to if someone has the flu, they feel very tired, because certain chemicals in the immune system bring that out. And then we talked a little bit, you mentioned about the holistic approach. Smoking, of course it's bad for your lungs, it's bad for your heart, but it's very inflammatory. So people who smoke have more problems. People on high salt diets actually have more inflammation. So we're trying, as you said, to eat clean and keep that part down. So back to the fatigue part with you, and you said we give people a checklist, but that primary fatigue is just from MS. But our job, your job, when I'm out or when I'm not here, if I'm when you're seeing your patients, is really to take care of that secondary fatigue. And the secondary fatigues are people who are depressed, and that's why they're fatigued. Also, what I think is interesting is that, and we've talked about this a lot at the office and at the center, is that people who are fatigued, almost all deserve a sleep study. And tell us a little bit about that.
Yeah, I mean, I agree with that. A lot of it is, we always assess their sleep patterns. Are they having issues falling asleep, staying asleep, or both? And if it's issues falling asleep, what are you doing before bed? There's recommended to turn off all electronics 2 hours before bed. Things like sleepy time tea, sometimes taking a hot shower because your body temperature goes up and falls, kind of like how we fall asleep. And what are you eating before bed? Is it something that will is there something sugary that will keep you up, or are you eating a large meal before bed? But yeah, I mean, a sleep study I think is often also overlooked. It could be underlying sleep apnea. That's why you're not, your body's not oxygenating. So that's why you have this daytime fatigue in particular.
That excessive daytime fatigue actually does cause a lot of problems. And if you can't get around, if you can't keep your eyes open, you can't function well. There's a statistic about 2/3 of patients will have some cognitive issues with MS. And we're seeing them more because people are living so much longer with it and doing well in a lot of ways. And that, just the same way with depression and anxiety, sometimes we don't pick that up unless you look for it. So that's what makes it so crucial with patients. So I'm going to say something to you. Having nurse practitioners in our practice at the MS Center of Staten Island has been amazing. The way you look at a patient, and no matter how many years I've done this as a physician, is very different than the way I look at them. The issues of sexuality, bowel and bladder function, things that people wouldn't think that they'd want to tell me. For some reason, I don't know why. They think that we're here to talk the medicine and this. But when a nurse comes in, and we have male nurses and female nurses, people who are comfortable with telling certain things to different people. The social worker, all the people who are there all have a different niche. If you're having a problem at home with your family, if there's issues, they always want to talk to the social worker. If it's a problem about sexuality, it's usually they like to talk to someone of the same sex, bowel and bladder problems. So everybody finds their spot in our center. So tell me a little bit from a nurse practitioner's point of view. As I said, it's been amazing to see what you guys focus on. You've been a nurse in the intensive care unit. You've been a nurse at different places. You've ran COVID centers. Dan has had more jobs than anyone I've ever known, and I'll tell you the beauty, has excelled at every job he's ever had. Exactly. So please tell us about when you see as a nurse, when you look at a patient, what do you see that's different, and why would our patients, or anybody who has MS who even wants to come for another opinion, whatever, why would having a center where a nurse practitioner is heavily involved be better or different than just by going to your regular doctor and saying, neurologist, internist, whatever, and going over, okay, here's X, Y, and Z, what we have to do?
Good question. I feel like it all stems from working bedside because we're with the patient for, 8 to 12 hours a day. And, we have a certain set of patients we're with. So we're kind of handling all of their needs and listening to all their concerns. So I think that's where it all begins. And that's how it carries over into the nurse practitioner field is now we just have more autonomy to actually act on what we want to do rather than, having to just, kind of go to the doctors and have them put the orders in. Now we can actually take care of the whole picture, the whole patient as a whole. So I think that's kind of where it all ties in as to why we look at it from different aspects, because we're kind of used to taking care of all different needs, no matter what it might be, at the bedside.
Super. So now we're going to talk a little bit about the treatment we have for patients with MS. And as we talked about really the first half of our half hour with everyone out there, all of our wonderful viewers, it's this holistic approach. The anxiety, depression, seeing how people are doing. Now we're going to go into what a lot of people want to hear about. But there's really two parts of it. One is symptomatic therapy, which if you have a symptom, what do we do? And that includes depression, anxiety, fatigue, but it also includes bladder problems. There are a number of medicines that we have. sexuality issues that we have, particularly with men using medicines like Viagra, different medicines similar to it. And there are ways that we could treat the symptoms. Stiffness, we have medications for it. We have a drug called baclofen. We've got various injections like Botox for stiffness. There's something called a baclofen pump. So there's multiple agents for different things. Tell me a little bit about how you assess those kind of things in patients.
Yeah, I mean, it's always a conversation with the patient too to see if they're even open to medication for it. Because a lot of patients are like, oh, I know I have this, I'll just deal with it, and don't want to be treated with medication because they're afraid, they look at the label and it's like 5 pages of side effects. But you ask them, basically you start asking them, what's wrong with them, what bothers them the most, or what bothers them the least, and kind of, attack it systematically, as you said. So if they feel like their walking is not as good, we have medication now for walking in MS. As you said, like the spasms, the stiffness, the tightness, muscle relaxers like baclofen can help. For sleep, I try to go more natural approach when it comes to sleep, such as supplements like magnesium glycinate can help, tart cherry juice capsules can help as well. So it's really a conversation with the patient to see, meet them where they're at. I never want to be like, okay, you've got 5 different issues, here's 5 different medications, because nobody wants to be on all these medications. But I always ask them, how badly is it affecting your life? And then if we could do things like physical therapy for the the stiffness or tight spasticity, or even for the walking to help with the gait. But I feel like it's always meet the patient where they're at, never push, but make suggestions like, if you have this issue, this is the treatment for it, and always leave it up to them to make the decision ultimately.
And having physical therapy, occupational therapy, speech therapy. A lot of people don't know that occupational therapists do a lot of cognitive remediation, helping cognition. And a lot of people with MS have difficulty with executive functions or multitasking. So there are ways to get through those kind of things. We've had a lot of experience with MS, not just as our center, but even nationally and internationally. So there are methods to get people better, to handle almost any problem they have. And what I think I hear more, and this is where you guys get this more out of patients because you do it a little bit more systematically, is people don't believe that certain symptoms are related to MS. So someone is constipated. That could be from their MS. Again, it's not the first symptom that if someone comes in with constipation, you should evaluate someone with MRIs or spinal taps or even any part of the exam. No, that's very rare. But if you do have MS, not being well hydrated, having constipation, having bladder issues are very common symptoms that we have. Not just weakness, not just slurred speech, not just blurred vision or double vision. And that's really the kind of things that we look at. I'm going to take our last few minutes and talk about disease-modifying therapies. What's different about MS now than when we first started our center in 1992? What's different is we have medicines that dramatically change the role of how people do, that affect the immune system. We've learned so much about the immune system being an MS specialist and neuroimmunologist. Basically, we learn about the immune system and figure out what parts we could block. And here's where things have changed over the years. When we first started with some of those shots that came out in the 1990s, they were low effectiveness, low efficacy agents. Some people did very well on them, of course, but it was great to have some of these medicines. But a lot of the medicines didn't do enough. And they did this huge study in Europe. It's in a Scandinavian country where everyone was captured. And they said if you started on a milder agent and saw people out for 8 years, the first 2 years, and versus someone with a higher effectiveness agent, a higher efficacy agent, we get a little bit more side effects, but it does affect the immune system in a stronger way. The people for the first 2 years are about the same. You don't see that much of a difference. But by year 6, 7, and 8, it spreads apart. There's much more disability in people who started on lower effective agents. So right now, over 50% of people are on the medicines you hear about on television. They're called anti-CD20s. They take one of your lymphocytes, which is a kind of white blood cell, and actually make it go away for a period of time. It's called an anti-B cell therapy. We have other kinds of things that block these lymphocytes, and these are the cells that attack the myelin, from getting out of the lymph node. They're called S1P modulators. We have medicines that block almost all of these from getting into the brain and spinal cord. There's a drug called natalizumab that does it. And these higher effective drugs have changed the way we work, have changed the way people are doing. People with MS many years ago, it was a terrible diagnosis. It's still a terrible diagnosis to have. But right now, people live normal, very close to normal lifespans. And the sad part, some of the things that actually lower their life expectancy for people with MS is suicide. Especially, you mentioned depression early on, getting that diagnosis. So it's so crucial that you be at a place, or even it could be local doctor too. It doesn't have to be at a major MS center like ours, but it could be at any place where they're aware of it and can talk to you about it and help you get through some of the hard times when you have that type of a diagnosis. But we've really come a tremendous way with it. So tell us then, in a few minutes, what have you learned at the MS Center in the last 6 years?
I've learned a lot. Where do I begin? I learned a lot about MS in particular, but you see it. You kind of see, I said patients who are very young, to even patients who I'm seeing, in middle age that are getting diagnosed, and it has come a long way. I think there's over 20 FDA-approved medications for the treatment of MS, like disease-modifying therapies, and patients are doing better, which is, I think, most important. And it's, as you said, people hear a diagnosis of MS, they're so worried that they're going to end up in a wheelchair. But again, I think, what our method has been is really, giving the strongest medication so we can preserve them longer term, and really getting it instead of, really tackling it head on, should I say. And we're very close with our MS patients, and we follow up very frequently. So I think that also plays a role. Patients know that they have good care, and that they're being cared for, and that they're not just a number.
Yeah. Thank you. And really, just to conclude, there are over 20 medicines available that are called disease-modifying therapies. If the first medicine doesn't work, there are other medicines. I say this at all my lectures to large patient groups. How many medicines do I need for MS? I need one. I need a cure. If I don't have a cure, how many medicines do I need? I need 1 million, because there are 1 million people in the United States. Some people would rather take a shot, an intravenous once every 6 months, one that's every month, a pill every day. There are different ways of using medications. And that's the important part of this, that we can find a medicine for you both for the symptoms and for the disease itself. What I think is so crucial about this is that there are treatments available. I wish I can guarantee, and any MS director or any MS specialist could say that you're going to do great. But overall, a large majority of our patients do. And I think that's so important. For the people who are not doing well, it's not that you've done anything wrong. It's our medicines just haven't gotten there. And then over the next couple of years, we learned a lot more about immunology. And we are going to come up with some new medicines that are coming out there that will block MS and this inflammation in a different way. Something called, just for anybody ever hears, it's called a BTK inhibitor. And there's going to be more and more research coming out. We're part of the consortium of multiple sclerosis centers internationally and nationally. So we're really on the cutting edge of this. So I want you to know that all of us at the MS Center of Staten Island want to say thank you. Happy to see anyone who wants another opinion. And you can do well with MS. And that's where we are right now. And I want to thank all of the patients and people who have been with us all those years, and the wonderful staff at the MS Center of Staten Island. Have a great night, everyone. Take care.